Okay, good evening, everybody. Welcome to the second part of this sort of two-part webinar in conjunction with UK CREAM, the Clinical Reasoning in Medical Education group from the UK. And we're looking at clinical reasoning. We're looking at the what, the how, and the scholarship. Hopefully, most of you who are attending have had the opportunity to look at the pre-recorded session where we just introduced some ideas just to trigger a few questions. We're going to look at some of the key areas that we highlighted in that over the next few minutes. I'm Mark Lillicrap. I'm a rheumatology consultant. I'm curriculum subdean at University of Cambridge. I work with the ASME board as their director from the membership, and I'm on the committee of organisers for UK CREAM. I'll get Nicola and Simon to introduce themselves as well. Nicola, just give us a brief introduction of yourself.
Good evening, everybody. My name's Nicola Cooper. I'm a consultant physician and clinical associate professor in medical education, and I'm chair of the UK Clinical Reasoning in Medical Education group.
And Simon.
Good evening, everyone. Simon Gay. I'm a GP in the UK, and I'm professor of medical education at Leicester Medical School. I'm treasurer of the UK Clinical Reasoning in Medical Education group, and I'm also on the Educator Development Committee of ASME.
So we're here, but we're not here to sort of give information. What we want to do is get a bit of a conversation going. So it'd be great if you're able to use the chat function, contribute ideas, ask questions, and as I say, get a bit of discussion going. Just a sort of few general housekeeping things before we really kick off. So this session will last approximately 45 minutes, slightly dependent on the questions that we've got and how we're doing. Please use the chat field if you want to ask a question. When you post the chat, please can you make sure that you select the panelists and attendees option, because then everybody can see the questions that are being asked, and we'll be able to see the questions that you want addressing. We are recording this, so it will be available online, and the ASME office will be circulating around a link if you want to access it at a later time point. If for any reason you're getting technical problems during the course of this webinar, do contact the office on events@asme.org.uk. In the pre-recorded session, we looked a little bit about, well, what do we mean by clinical reasoning? And we looked at Michelle Daniels' definition from academic medicine, a skill, process, or outcome wherein clinicians observe, collect, and interpret data to diagnose and treat patients. Clinical reasoning entails both conscious and unconscious cognitive operations interacting with contextual factors. And we explored a little bit of that in the pre-recorded session. Some sort of key elements that we pulled out of that. There's sort of four key areas. There's the data collection element, there's data interpretation, there's cognition, and there's a patient perspective. And as Nicola pointed out in the video section of the pre-record, our overall aim in this is to improve patient care, and we mustn't lose sight of that as the end outcome that we're looking at. The UK Clinical Reasoning in Medical Education group have put together a consensus statement around clinical reasoning based on a review of the scholarship that's due to be published in medical education. And the review identified 5 key whats and 6 key hows that we unpicked. So what should we be discussing and teaching with our learners when it comes to clinical reasoning? So we need to be thinking about clinical reasoning concepts largely so that we have some sort of shared language that we can discuss clinical reasoning aspects with. History and physical examination, particularly evidence-based clinical assessment being key. Choosing and interpreting diagnostic tests, understanding sensitivity, specificity, understanding the likelihood ratios in terms of what we're looking out for. The fourth thing was problem identification and management, and the importance of that in the reasoning process and how we do that, and shared decision-making. Shared decision-making with the patients, shared decision-making with other professionals within the team. And then we looked at the how of clinical reasoning. We need to build strategies that build understanding. So we want to think in terms of scaffolding. We want to think in terms of spiral curricula. We want strategies that employ structured reflection, and reflection is a key element. It's not what you're teaching and delivering that is important, it's what the learner is learning from the experience. We need practice with cases with corrective feedback, and for that to work well, we need to be able to have supportive developmental conversations with our learners. We need to have strategies that structure knowledge around the problem-specific conditions. So that links in with the importance of problem representation as a key part of clinical reasoning. We need strategies that employ retrieval practice, and we need strategies that enable learners to come back to things on regular occasions and build on different stages of learning. And we looked a little bit at the sort of RHYME acronym in terms of the development of reasoning strategies that we may unpick a little bit further as we went through. One of the key hows that we picked up that doesn't make a difference in terms of end outcomes is actually teaching about things like unconscious bias doesn't actually alter your outcomes, and we may want to discuss that a little bit this evening. So that was by way of a little bit of background as to what we covered in the pre-session material. So what we want to do, as I say, is we want to open that up. We want to open that up to a little bit more discussion. And so I'm going to stop the screen sharing, and we're going to look a little bit. There have been a few questions that have been asked both on the chat, and we had a few that came through in advance. And so perhaps what I'd like to do first is pick up one of the questions that came through in advance, which asked about assessment, particularly in the context of physicians associates. But it was about, well, how do we go about assessing clinical reasoning? Nicola, can I hand over to you first of all? Well, because we had a little bit of a chat about this. Talk us a bit about your thinking around assessment of clinical reasoning.
Yeah, thank you. So Ria Agarwal has asked the question about how we can practically assess clinical reasoning skills, either practical assessments or written assessments. And the best thing to do, I think, is to refer you to the scoping review by Daniel et al., from which that definition has come. They did a scoping review on assessment methods for clinical reasoning, because people have tried lots of different things. At the end of the day, a lot of clinical reasoning assessment is really, have you got the diagnosis right? Or it may be measuring underpinning knowledge. And so I would mention, though, something useful, which is you could probably try assessing the different domains of clinical reasoning, those 5 domains. So evidence-based history and exam, choosing and interpreting tests, this idea of, can you accurately represent a problem before you attempt to solve it? And can you share your decision making by using a guideline or a decision aid or a score, etc. We very often reduce things down to history examination, tell me what you think's the diagnosis. And we often assess on whether you've got the diagnosis right or wrong. We know that the process really matters as well. You can get the diagnosis right for the wrong reasons. So I think my answer to that is read that paper, which scopes out and looks at all the different assessment methods that are out there, and it talks about what they all try and measure. But I think there's definitely scope for us, certainly for formative assessment, to start, and feedback, to start thinking about those different areas of clinical reasoning education.
And I think just picking up on some of the other stuff that we discussed, linking in with the fact that it's not necessarily about the end outcome, it's the process that's important. And we talked a bit in the pre-session about RHYME, Louis Pangaro's model of the reporter, the interpreter, the manager, and the educator. And I know, Simon, you introduced us a little bit to that, and that can help us think about how we might go about assessing. Did you want to comment at all on that, Simon?
Yeah, there's a few things I'd bring in. I will answer your question about RHYME, but even coming back to something Nicola said, I think it's quite important to decide what you're wanting to achieve with your assessment. For example, if you're performing a formative assessment, you may well actually be wanting to almost do an educational diagnosis about what's working well in this particular person from their reasoning point of view and what's not going so well. And you can construct various opportunities to view that through setting up different scenarios. Whereas if you come into a summative assessment situation, you may want to do that same thing, but you'll have to spread it over a wide range of samples, for example, in an OSCE. And you want to make sure that you don't just have a learner that can give you the correct answer, but you want to have a learner who can give you the correct answer for the correct reasons. And I'd hand it out to the audience. Would you rather have a doctor who got it right this once, but for completely the wrong reasons, or who someone had very logically thought through, but on this occasion hadn't got the right answer? And I think that amplifies what we're trying to achieve when we assess clinical reasoning. Coming back to RHYME, I think what RHYME does for me in my day-to-day clinical practice, and for those of you who haven't seen the video, RHYME, the R is reporter, the I is interpreter, the M is the manager, and E is educator. And it's a way of stratifying how or where learners are on their development of their ability to practice independently, if you like. And what that does, or does for me in clinical practice, is it gives me an opportunity to know which things they need first. So if they can't do the reporting stuff or the interpreting stuff, there's no point questioning them on the management. You're better off working on the earlier parts, and then once they've got that right, you can move forwards. So that can give you an opportunity to stratify.
Just to talk about OSCEs, they're a beautiful example of how we make a checklist of people going through a process, and yet they could have completely missed the point. And I think we need to find a better way of assessing the process of clinical reasoning, not that you've superficially gone through a superficial process, if that makes sense.
Yeah, and then come out with the answer we were looking for. I think that speaks as well to workplace-based assessment and how situating assessment in the area in which it is actually going to take place as a genuine activity can be useful. For just those reasons, Nicola, I completely agree with you.
Now, we seem to have lost Mark, but I'm sure he'll come back. But Ria also asked some other questions. So Ria teaches physicians associates. And so she asked a question about, we mentioned how understanding the basic science mechanisms of disease can help aid understanding, and that improves clinical reasoning ability. And she asked a question about, in PA programs, that underpinning knowledge is different. It's more limited. And so she asked our opinion on how that would impact, and also talked about how she teaches using a contrastive learning. So I'll just address that really. I think in terms of physician associates and things like that, you can get so far with a decent superficial understanding and pattern recognition of common things. And that's why physicians associates and all of us work in a team. Myself as a junior doctor, I eventually realized when I became an SHO after a while that copying and superficial understanding only got me so far. And it was then I had to really develop an understanding of stuff. So I think, we work in teams, and there will always be a situation where something similar isn't actually the same. And that's when we need experts as part of our team. And the cases that you use to teach, so ACS, PE, costochondritis, reflux, and then getting people to think about the different presentations and so on. That's an example of mixed practice or contrastive learning. That's been shown to improve clinical reasoning ability because it helps to get knowledge into long-term memory. And from some research I've done, it works really well, but not for very novices, because they have to have that knowledge in the first place before you can start mixing it up, if that makes sense. So those are the questions from Ria, and we've got Mark back now, so that's good.
Yes. So I noticed in the chat questions that we were picking up, so somebody was picking up a little bit about the semantic qualifiers that both of you highlighted in our last session as being really important in that problem representation, and a little bit about the evidence for that. Did either of you want to comment a little bit on those semantic qualifiers and why they're so important in defining problems?
Yeah, I don't mind starting off. So just first to explain what they are. So a semantic qualifier, semantic means language. Semantic qualifier is in clinical reasoning, it's a binary abstract descriptor. So it's acute, chronic, mono, poly, unilateral, bilateral, that kind of thing. And that's part of a bigger thing called semantic competence, which is this use of precise medical language to convey very succinctly and precisely to others, but also to yourself, so that you can go into your long-term memory more effectively and retrieve information relevant to the case. What's really interesting, if you really want to know about this, read anything by Georges Bourdage, because he spent his whole career looking at this. He's not written loads, but what he's written is absolutely fantastic. And there is evidence that expertise correlates with semantic competence. But we don't know if being able to speak in a much more precise medical way makes you better, or if you just speak like that because you are more expert, if that makes sense. But only because no one's really researched it. We know that if we go back to remember thinking about type 1 and type 2 thinking, type 1 thinking is that implicit, intuitive, not associated with language type way that we make a diagnosis, for example. But type 2 thinking is associated with language, and it uses working memory. And in psychology, there's something called semantic memory. And so there is something about how we represent the problem mentally in our head using language that helps us to make a better diagnosis, particularly when the case is more complex, and there is good evidence for that. And that's why I think we need to teach it.
Yeah. And Simon, perhaps I could ask you just to comment a bit in terms of how we incorporate that into the curriculum, because that was one of the things that's in the question. Any thoughts on that?
Yeah. So I'll just again add another part to all Nicola said from the Georges Bourdage point of view. One of the other papers that Georges Bourdage contributed to the clinical reasoning discussion is a clinical diagnostic thinking inventory, which is a self-reporting instrument that has been widely quoted across publications in this area. And when Bourdage, Janet Grant and Marsden developed that, I think it was in 1990, Medical Education, if anyone's interested in looking at the paper, the two areas that inventory looks at are flexibility of thinking and structure of memory. And this comes back to the learning science theories around organized laying down of memories and improving recall. Whilst we don't have evidence to support this, it's perfectly reasonable to think that if you speak in a particular way about clinical cases, it might help you index them in your brain in a more organized fashion. Yes. So although we haven't always got the evidence we have got does interconnect with very much common sense, if you like. Yeah. And that's good. But to come to the introducing this into undergraduate curricula, for example, the fundamental challenge with all of our clinical practitioners disciplines is that you do have to learn a foreign language when you first come to it. And there's no getting around that basic requirement to know a certain level of information and to have the terminology accurately defined to you. And I think that links back into Nicola's previous comments about comparative learning, for example, where you can use it, but you can't use it instantly with an absolute beginner because they just don't have enough to make sense of what they're doing. And I think it's the same with the language. You sometimes just have to sit down and learn the basics. And then when you can do that, it's important that your tutors give you constructive feedback, both when you're using the language correctly, but also when you're using the language incorrectly. And one of the spin-offs, I think, of that we can use to home in on clinical reasoning opportunities to teach is when people are using colloquial or non-professional vocabulary to describe a situation. And that isn't necessarily a problem in itself, but it might tell you that the learner is not necessarily thinking about the situation in the most logical of ways.
Yeah.
I think there are lots of other ways you can do this, but I think those two are probably the simplest and most commonly needed.
Okay, yeah, no, that's great. I'll move the questions on, because one of the other things that's been picked up by one of the attendees is that bit around utilizing likelihood ratios in our thinking, and one of the important elements of what we teach being choosing and interpreting diagnostic tests, as well as evidence-based history and examination. And the question is, how do we find information on those likelihood ratios for different clinical findings, different test results? The question's from somebody who teaches in a general practice setting. But Nicola, I know you've done a lot of work on the sort of likelihood ratios. Did you want to pick up that in any way?
Yes, because it's not easy to find. So they don't, likelihood ratios and things don't exist for every condition, but a good place to start is anything written by Stephen McGee, who's an American physician who's really pioneered this. And you can look at JAMA, the Rational Clinical Examination Series, JAMA online. And you can look at his book, Evidence-Based Physical Exam. But also, I find good review articles. So you can often just look in the BMJ, Clinical Review, and very often they have very useful information about the probability of findings in that particular disease and how good those findings are if they're present. Because that's the kind of thing that we really need to know when we're making decisions, estimating clinical probability, not just, a list of features that kind of doesn't really help. So that's where I would look. I'd start with JAMA, Rational Clinical Exam, Evidence-Based Physical Diagnosis, and good review articles, often in the BMJ.
Yeah. I would echo. The one of those that I've used and so have experience of is the evidence-based physical diagnosis. And that I actually find odds ratios quite challenging, not because they're empirically difficult, but because remembering them, the detail of them is actually quite difficult. So I think picking some of those off, in particular, some of these resources talk in systems-based terms. So perhaps picking a system off at a time rather than trying to ingest them all at once is a good way forward.
Yeah.
I mean, I'm terrible at maths, so I just after I've read it, I take away the main messages. Things like, this is pretty useless as a physical sign in this condition, and and we do get lots of junior doctors with misperceptions about findings, like my example, pulmonary embolism, but the oxygen levels are normal, so I didn't think about PE. Well, that's actually irrelevant, so these things can be very important.
Just picking up another question that's come through about really about the how and how we do it, and how do we translate that online with things becoming remote? How do we enable that clinical reasoning process to take place in a non-face-to-face kind of environment? And I think if I just pick up first, I think it's partly about that paradigm shift. It's not what you deliver, and I think one of the dangers of remote teaching is there's a lot of delivery of information, whereas actually all the evidence shows us that effective clinical reasoning education is around what the learner learns, and it's enabling the learner to explore their own thinking and to utilize those kind of tools that we've discussed already. And so using things like breakout groups, getting people to do things in pairs in small discussion groups, and then bringing them back to the whole rather than delivering things. But Simon, did you want to add anything about sort of remote teaching?
Well, the first thing I'd acknowledge is that I know Nicola's doing some work at the moment on some online and distance resources for clinical reasoning. So I'm sure we should come to her in a second.
Absolutely.
Well, there are a couple of challenges in moving online for me, and I accept completely what you've said about the learner learning already. There is a challenge in taking clinical reasoning activity online. Firstly, because I think clinical reasoning activity is very heavily based in the clinical experience. And I think I promoted in our recording before this Q&A session that you can always encourage the learners to anchor their reasoning to the patient in front of them, because we teach them generalized concepts and then we ask them to hone down to the specific. And Nicola illustrated that beautifully with the PE and O2 level aspect there. And it's harder to do that online. I think people can very skillfully do that online, and I think Nicola will talk about how to do that in a moment. But it is harder to do it online because you inevitably risk reducing a clinical reasoning scenario to a linear series of information gifts. And it's very hard to give that information without cueing an answer.
Yes.
Now, I think things have moved on a lot in the last decade in that regard, but it is still difficult to replicate the messy complexity of parallel lines of activity and thought that go on in a daily clinical consultation. And I think that adds a layer of challenge for all of us when we're educating learners. That said, in the pandemic now, for example, that's where we are. We're faced with that. So going online is much better than not going anywhere.
Yeah. And it picks up what you were saying in the last presentation about contextual factors being key. But yeah, I'll come to Nicola, because as Simon mentioned, you'll be doing some work on starting to develop some online resources. So Nicola, do you want to pick that up a little bit in terms of the work you're doing?
Well, I guess I'll echo what Simon says. There's lots of things you can do online if you look at the fact that clinical reasoning is highly dependent on knowledge, and if you look at the different domains of clinical reasoning education, and if you look at all the different ways that we can teach it, there's a lot that you can do online. But ultimately, the other bit of medical knowledge is that experiential knowledge. So in our memory, we store knowledge as illness scripts, which is connected to the patients we've seen, their physical signs, and so on. So you clearly, everybody knows that to be a clinician, you have to see patients. That's quite simple, but there's still a lot of other things that you can do. One of the things I would just mention about case-based learning, because I think that's so there's underpinning knowledge, that's kind of fairly easy, but case-based learning online is there's a few things that you probably need to do to make it more effective. And I'm involved in a project where we're trying to do just that. But the few key things are use a whole case approach, not a serial cue approach. So that means don't reveal the case bit by bit. Have all the information available for learners so they can see it all at once and go to it when they need to. That reduces cognitive load on their working memory, so they can put their effort into solving the case. The other top tip is show, don't tell. So the worst case-based learning online is things like, Mr. So-and-so, a 50-year-old heavy smoker, type 2 diabetic obese lorry driver, comes in with central crushing chest pain radiating down both arms, and his ECG shows ST elevation. That's the worst type of case-based learning, because everything is handed to you on a plate. And part of clinical reasoning is problem identification, problem representation, also gathering data, interpreting data. So if we can replicate those things as best we can online, you know, in the patient's own words, showing the x-ray, showing the ECG, and we can do those things, that's the best way to do it. And also get them to do the problem representation. Don't ask them what the differential diagnosis is first.
Although just picking up on what you just said there, Nicola, I think it's interesting because it links with a couple of the questions that have come through. You used a number of semantic qualifiers in your description of that patient that activated our illness scripts. And actually semantic qualifiers are a way that it enables us to access our sort of stored illness scripts. And it's why we find that so difficult to avoid in terms of unconscious bias and things. And we've had a couple of questions that come through that link in with that. Should we be teaching more novice students in advance about semantic qualifiers before they come into the clinical environment? And secondly, how does that sort of contrast with the guidance that is sometimes given that a more junior student should be doing the reporting level of rhyme, just using the patient's own words and not using semantic qualifiers at that stage. Did either of you want to comment at all on those two areas, that both picking up different elements of semantic qualifiers?
Yeah, I'm happy
Yes,
to come in there. Yeah. So to take the first question, I think the more you can inculcate the vocabulary with people as early as possible, the better. I think as long as you do that in an interesting and engaging way, and not just give people a boring list that they have to learn, I think that can only be good, because you then create a groundswell of knowledge that they can move forwards with. And I remember having conversations with some of the people on this webinar today about when do you start, and I think for me it's as early as possible, really. The second part of that question about whether you encourage people to report their findings in, for example, the words of the patient, or whether you resort to translating that into semantic qualifiers and other descriptors we use in our medical jargon, if you like. I think both aspects are important, but you can start by encouraging novice learners to report the findings to their tutors using the words of the patient. And then when you ask them to summarize the case for you, you can ask them to summarize it using semantic qualifiers and other descriptors we use when we're talking to colleagues about a case. And I think that actually gives you the best of both worlds.
Excellent, thank you. We've covered a lot of territory so far. Just to pause briefly, so we've looked a little bit about assessment of reasoning. We've looked at assessing the process versus necessarily just assessing the outcome. We've looked a little bit at the rhyme, the reporter, interpreter, manager, educator, and how that framework can help us think a little bit about how students are developing their clinical reasoning. We thought a bit about likelihood ratios and some of the resources we can access for evidence-based approaches. We've thought quite a bit about things like semantic qualifiers and some of the things that we can use as strategies to help people to learn. So we've looked at a fair variety of questions. What I'd like to do is just shift slightly. A question that we got in advance was around how can we use other students to help with this teaching? And the specific question was around sort of peer teachers. And so very often we will use senior students to teach more junior students. Sometimes we'll use quite junior doctors to teach more senior students. And how can we best use peer tutors in this kind of teaching? So Nicola, shall I send that one in your direction in terms of peer teaching and clinical reasoning?
Thanks. So this was a question by Hadis Rehani. So thank you very much. What's the role of peer tutors in the undergrad curriculum in teaching clinical reasoning? What teaching and learning theories can be employed by senior students? Hadis, my answer to that question is go to www.learningscientists.org and ideally read their book, Understanding How We Learn, a visual guide. It's amazing. You as a peer tutor can use some really great strategies such as elaboration, retrieval practice, so low stakes quizzing, and structured reflection, where you get someone to list the findings compatible with that diagnosis and list the findings compatible with a different diagnosis, that contrastive learning. There's lots of cool things you can do, which are all designed to get knowledge into long-term memory and build understanding. And knowledge is about memory, and getting things into long-term memory means you're better at clinical reasoning in a nutshell. And studies have shown that. Yeah.
And I think it's really important that actually peer-based teaching really enables learners to start to unpick their reasoning skills. It's often, if we think of sort of Maslow's hierarchy, it's a much safer learning environment with peers than necessarily somebody who's senior, who's doing a lot of that sort of type 1 thinking that Nicola identified earlier. And that feels like quite an unsafe and insecure environment to a more inexperienced student. So actually getting students and more junior people to to have those developmental discussions, to discuss reasoning, to explore why you're thinking that way is actually a really useful way of helping learners to learn. Simon, did you want to pick up anything additional about peer teaching?
No, nothing really. I mean, I completely echo what Nicola said, and I was thinking as Nicola was describing that about how much safer absolute novices will feel with a peer. And you don't need to know an awful lot about an area in order to know which are the right questions to ask. And you can actually mutually peer support rather than one person being the supporter and the other person being the recipient of that support.
Just going to come back to questions that have been coming in from our attendees. So one of which is around evidence-based clinical examination, and actually how good is our evidence base for evidence-based examination? How well does it map to underlying pathologies? And my take on that is it's actually very variable, and a bit like we discussed earlier, it can be quite difficult to access the information. I'm quite fortunate, I guess, as a rheumatologist. So things like the GAL screen were specifically developed thinking about the sensitivity and specificity of different elements of the examination routine in a way that a number of other examination routines haven't been developed. But Nicola, did you want to comment at all on the how do we go about doing evidence-based clinical examination?
Yes, I think Marco's right that likelihood ratios, for example, and the evidence base exists when we've got a sort of definitive test to know if someone actually has that disease. Like a chest x-ray in pneumonia would be one example, but there are remarkably quite a lot of those. But the problem is you have to go and look at journal articles or just the one book that we've mentioned, evidence-based physical diagnosis. So it's not in one place. So if anyone here would like to write the definitive textbook for general practice, for example, now is your chance.
Can I just add to that?
Yes, Simon.
It's really important where the evidence exists that people have access to it. But it's also useful to know where the evidence doesn't exist, because there are many things we do in our clinical practice that perhaps we've almost been led to with the presumption that it's evidence-based, and when you actually look for the detail, it's either hard to find or it's nowhere in sight. And that can also inform your clinical reasoning, because you then are basing it on a greater awareness of what is and isn't proven.
I'm going to pick up another question which links with the importance of basic science as a foundation to our reasoning. If we are to show how basic sciences provide coherence to clinical practice, how should a curriculum go about it? So how do we structure a curriculum to ensure that basic science provides coherence to clinical practice? Simon.
As a starter for 10, I would propose that we need, wherever we can, to link the science we're trying to teach to the clinical scenarios, cases, reasons for knowing that information. Now, I'd be the first to say that not everything we're taught in basic science can be directly translated that way, and that some of the things we need to learn in basic science are stepping stones to learning other things later on that we need to learn for clinical practice. So you can't do it with all of it, but there's a lot of the science that's taught in early years of clinical education in all sorts of health professions that can be very quickly brought to life for the learner by using clinical context.
And I think that fits particularly with another comment that's come through about, surface anatomy and how we apply surface anatomy. That works so much better in a clinical context than just as a sort of theoretical framework.
My first ever teaching session in a medical school was teaching the surface anatomy of the chest as part of an anatomy dissection class. So I completely align myself with that comment.
Yes. And I think in many ways, in terms of the basic science can't always be integrated directly. But actually, we very often fall back on our basic science, particularly when we're faced with uncertainty and we're faced with difficult situations that don't map to illness scripts and things that we're used to. Actually, we can drop back into that sort of more hypothetico-deductive analytical reasoning that builds on the basic science. And I'm not entirely sure there's ever an absolute right-wrong answer as to how you teach and where in the curriculum that basic science fits, because we each of us learn in different ways. But as you've picked up, Simon, I think the key thing is to try and contextualize it in order to facilitate depth of learning. Nicola, did you want to add anything on the sort of the basic science and curriculum side?
Just to say really that I went to a very traditional medical school many years ago, where a lot of what we were taught probably wasn't relevant, but actually also a lot of what we were taught was relevant, but I didn't realize it till much later. Experts are a bit of a paradox, because most of the time they don't use basic science in their thinking, and they would struggle to maybe explain some things in as much detail when describing a pathology or something. But they do revert, the research shows, to understanding basic science mechanisms when thinking things through, when the case is a bit less familiar or tricky, for example. And here's a beautiful example I alluded to earlier, when similar is not the same, and that underpinning understanding matters, is the time as an SHO when I found the consultant cardiologist giving intravenous beta blocker to a woman in crashing LVF. Those were the days when beta blockers were banned in LVF. Now, why on earth was a consultant cardiologist doing that? She had very severe mitral stenosis and she'd gone into atrial fibrillation. Now, just think about that for a minute. The LV was normal, tight mitral stenosis. When it goes into AF, that rate is what's putting her in crashing LVF. And when I reflected on it afterwards, I thought, yeah, that was the right thing to do. Yeah. He's an expert. Yeah. And that's when that knowledge, that underpinning knowledge, can really make a difference. When, you know, you're doing something that makes sense from a physiology point of view.
Yeah. I'm aware of time. I'm going to come on to the last question we were asked in advance was, in the context of sort of shadowing, 5 top tips. What would be our top tips on clinical reasoning based on the sort of scholarship that we've been reviewing? So let's go around with a few top tips for people. Simon, any particular top tips?
I think the first thing is create a safe environment. You touched on Maslow's hierarchy of needs, and Nicola's talked about cognitive load. We need people to be sufficiently relaxed in the clinical setting to be able to think about the problems we're putting in front of them. Yeah.
Nicola.
Thanks. So this is a question from Mandy Jane Gray, and it's about top tips to facilitate clinical reasoning when you're shadowing health professionals in a busy environment. My answer really is that shadowing is passive, and that's the problem. And if you look at our components, our domains of clinical reasoning education, you have to do them, if that makes sense. You can't observe them and learn. And can you send them to go and see a patient first, for example? Can you get them to do some of those things in our strategies, like contrast what they'd expect to find if it's this, or what they'd expect to find if it was that, or come back to you and do self-explanation, or practice problem representation after you've seen the patient together. So is there any ways that they can shadow while making them do? That's what I would recommend.
The next thing I would pick up is, in terms of a top tip, I'm quite a fan of the 1-minute preceptor or the 1-minute teacher, just as a way of exploring clinical reasoning. And it just encourages you to ask open questions, because you need the learner to articulate their thinking. And then you just probe their thinking a little bit by slightly changing the scenario. So what if this was different? And I think it's just a useful framework to enable us to have those developmental conversations in the moment, in a sort of productive way, and encourages us to ask open, creative, upper end of Bloom's taxonomy kind of questions, rather than just asking people for lists and knowledge recall. So the 1-minute teacher, 1-minute pre-lector would be my tip. Simon, I'll come to you for another top tip.
just make sure you feedback, and the feedback's a dialogue. Because I think when you're having a conversation with someone about a clinical entity and you're assessing their reasoning, it needs to be a two-way exchange, not simply you delivering the correct answer.
Yeah. So excellent. So we asked for 5. Our 5th top tip for the evening before we finish.
Say that again. Our 5th.
Our 5th top tip. We were asked for 5.
Read our consensus statement.
Excellent.
It's got more detail. It's been accepted for publication in a journal called Medical Teacher. We're going to make it open access. It should be online soon. And it's got lots of references as well, so you can go and explore more. That's my 5th top tip.
Excellent. Thank you very much. Simon, did you want to add anything there?
Nothing to that. I just wanted, if we're about to close, to thank Jim Boyle from Glasgow for providing the references in the chat while we've all been talking. Jim's a member of the CREAM group, and it's been very helpful him doing that.
Yes, so thank you to all of you. Thank you for attending. Thank you to Nicola and Simon. Thank you for those of you who sent in questions in advance. We hope you found that a useful and interesting discussion. As we mentioned earlier, this is being recorded. The video will be available. It's likely to be a day or two because it needs to be edited before it's put up. But the ASME office will be circulating around details of where the video is and how you can access that. As say, there are a series of bite-sized sessions. The next one is next Monday, the 9th of November. It's a lunchtime one with Johnny Gukian, who's the ASME Director of Social Media and Communication. And he's going to be exploring with Dr. Kamal from the University of Faisalabad in Pakistan, a bit about social media and how the use of social media influences our professional identity formation as doctors. So sounds fascinating. For more details, have a look at the ASME web pages. There's more information there. That's it for this session. I say hope you found it useful. Hopefully you've managed to pick up some of the references that have been put up in the chat as we've gone through. Thank you very much for engaging, and thank you to the ASME team for putting everything together. Thank you.